Sir is using another system. That's what sir is telling.
Okay. What is the name of that?
Sir.
Yes. Sir, just try now.
Okay. Dr. Prashant, check it.
Yeah. We can see it, sir.
You can see.
We can see and yeah.
Okay, so
Okay,
you
sir.
may start now. Yeah, please.
Okay. Thank you, sir. Good evening. I'm extremely happy to welcome all of you to this second edition of NutriTalk series. We are very fortunate to have our Honorable State President, Dr. Nandakumar sir here. He's a driving force behind this our nutrition chapter. I wish to welcome you, sir. Also, the State Secretary, Dr. Gobi Mohan, for his support in organizing this series. I wish to welcome Dr. Joe So, Professor Pediatrics, GMC Alapi, and Vice President, South Zone, IAP, to this meeting. I welcome Dr. Purushothaman, sir, who is the HOD of MES, and sir has kindly agreed to be the chair of the session. Now, I formally welcome Dr. Praveen Kumar, sir, Professor, Director, Pediatrics, Lady Hardinge Medical College, New Delhi, for giving a talk on this very important subject. Although in statistics, the numbers are less in Kerala, PEM is still a possibility and we have to tackle it. Sir is a senior pediatric gastroenterologist and a great academician. He is credited with many research publications and has organized many training programs over years. I welcome you, sir, to this program. I wish to welcome all the delegates for joining this, and I hope it will be you all will be very much benefited by this program. Thank you all.
Thank you, Madam. Dr. Joe, sir, South Zone Vice President, Central IAP. I request sir to address the gathering. Sir, Joe, sir. I think Joe, sir, is there, not there.
He's there. Jose is there.
Joe, sir.
Jose mute ആണോ?
No. Mute അല്ല. Video is on.
I now invite the President of IAP Kerala, Dr. Nandakumar sir, to deliver the presidential address.
Good evening all. Respected Chairperson, Nutrition Chapter, Dr. Geeta, Secretary, Dr. Jitu, State Secretary, Dr. Gopi, and today's Chief Guest and topic presenter, Dr. Praveen Kumar, then the great teacher, Dr. Purushothaman sir, and Dr. Jose, South Zone Vice President, and other dignitaries on this platform. As you all know, nutrition is very important for practicing pediatricians, then faculties and PGs, not only for exam purpose, but also in our day-to-day practice, it is very important. Even though Kerala, we are seeing less number of undernutrition, nowadays we are seeing a lot of overnutrition, and even some cases we are seeing, occasionally we are seeing undernutrition, even severe malnutrition and so. So we should know everything about nutrition because that differentiates pediatrics from adult medicine. So today we are very lucky to have a very famous and very good orator, Dr. Praveen Kumar from New Delhi. He is going to present integrated management of children with malnutrition. So over to you, sir. Thank you. Thank you very much for this opportunity.
So good evening, everyone. Thank you for the invitation. and opportunity to talk to you, all of you. So, although it's Kerala has lesser number, but then there are pockets where you have problem of such severe acute malnutrition. So, few years back, I was also involved in one of the pilot which you had in Attapari, Palakkad, when there was some few deaths, which was that time it was attributed to severe acute malnutrition. And few years we were having some project which was implemented through UNICEF in that area. So that is some working experience I have with Kerala. So coming to the topic for today, Dr. Prasant, I hope I am audible and audio is fine.
Yes, sir. Yes, sir. Audio is fine.
Okay, thank you. So topic I have kept it is integrated management of severe acute malnutrition, because over the years, as we know, now we have the component of community-based management of severe acute malnutrition, along with what we were having for a long time, facility-based management. So coming to the topic, I think all of us, we know this undernutrition is one of the important contributor to child mortality globally, and approximately in India we talk about it is much more than this. Few of the study they have reported up to 65% of child mortality which we have in India is being contributed by undernutrition. So that's the background which we have, and then we also know globally this is an important publication from WHO and UNICEF in 2006. When they publish this, when there is a child with severe acute malnutrition and he or she develops pneumonia, diarrhea, or some medical complication, then risk of mortality is approximately 8 to 9 times higher than normal children. And when we analyze our own data, which we publish this and our own hospital, so if you are treating them in the same health facility with similar type of no treatment which you are able to provide, then also in our hospital, what we observed approximately 3 times this increased risk of mortality in children with severe acute malnutrition as compared to children who were not having severe acute malnutrition. So that's a background, and we know there are studies where they have documented that if the mid upper arm circumference is less than 12.5, they have higher risk of mortality, as you can see in this slide. And that's the reason in WHO, this is what which I'm quoting is 2013. What they have WHO recommended in every health facility and hospital, the health workers should assess mid upper arm circumference or weight for height, weight for length, status of infant and children who are 6 to 59 months, and also examine them for bilateral pedal edema to identify children with severe acute malnutrition. So that is a strong recommendation by WHO, which was there in 2013. It's not only WHO, our own Indian Academy of Pediatrics also in 2013 adapted this, and they also published this guideline where they mention that if the child is fulfilling these criteria, then they should be treated as SAM and they should undergo assessment for medical complication and appetite test. How do we identify severe acute malnutrition? We have these criteria. Many of you, I know you don't see this routinely, but at the same time, the prematurity children, particularly in few of the pockets, you must be getting. So when the child, the first thing is that we have to take anthropometric measurement, and we have to calculate their SD score for weight for length or weight for height. And weight for height is less than -3 standard deviation, and or meet-upper arm circumference less than 11.5, and or if they have edema of both feet without a known cause of edema like nephrotic or other, then we classify a nutritional status as severe acute malnutrition. So I think this is the first step is identification. Unless we identify, we will not be able to. And for identification, what we need to do is to take anthropometric measurement, determine their SD score, whether it is uh, fulfilling or meeting the case definition of severe acute malnutrition or moderate acute malnutrition. So when they have weight for height between -2 to -3 and or mid upper arm circumference 11.5 to 12.4, and there is no edema, then we say this is moderate acute malnutrition. So the overall, this is what you see just now is overall our treatment strategy. So the center stage is definitely prevention of acute malnutrition, and that we will be able that we will be able to do by improving our infant and young child feeding practices, and improving food security at household level. So I know this is not a major problem in most of the states now, household food security, but many a times during flood or some natural disaster, there are problems, and we have to make sure that every state is ready to tackle and maintaining the food security at household level, particularly during natural disasters. But somehow, if this prevention of acute malnutrition and this fails, then we need to have routine active case finding, and this will be by growth monitoring, which we have as per our national guideline and most of the state guideline. All children less than 5 years, they are supposed to have.
Jitu, you are the host.
Sorry, there was some, yeah, yeah. So this is the routine screening is needed, and each health contact or monthly there should be weight, their length or height depending on age, and then there is determination whether this child is maintaining the growth trajectory or not, and based on that you decide whether this child has problem. And if the child is severely acute malnourished, then we have two level of treatment. One is facility based and the other is community based. Now they both are interlinked. When there is a facility, maybe we can request the participant to mute their audios.
Muted, sir. You can continue, sir.
Okay.
We'll take
so yeah, okay. So when these children are managed in in a health facility, so after treating their medical complication and initial management, they should be linked to community-based management for completion of treatment. And the children who are enrolled in community-based management, if they develop some medical complication, they should be referred to health facility. So that is what the overall program strategy is, and which we say this is integrated management of severe acute malnutrition. How do we decide? You look for medical complication in a child with severe acute malnutrition. If there is medical complication, admit them. If you have NRC, you have few NRCs, particularly in Attapari, and few of the other districts also where there are some pockets of severe acute malnutrition, mainly the tribal population. And when there is no severe medical complication, then ideally the appetite test should be conducted. If the child passes appetite test, then they should be enrolled in CMAM. And if appetite test fails, then admit in NRC. So that is what we have. Now coming to our own problem and why we all need to be sensitized and we should practice this, because we have very high prevalence of severe acute malnutrition. As we know, the wasting is in the tune of 19% overall in the country, and which is quite high. And also it is, we have a different pattern because many we have very high prevalence in first 6 months of also, which you can see in this slide. So what is happening typically in South Asia, the high prevalence of severe wasting is right from birth because we have low birth weight, quite high, and then this declines rapidly in first year, and then this is almost static. While in African countries, you do not have such high severe wasting right from birth. So in these countries, most of time the onset is usually after 6 months. They have increased, so they have more of the complementary feeding problem. So when we talk about management in health facility, I think most of you must have read it, but just to reorient, there are 10 steps which WHO or our Indian Academy of Pediatrics they have given, and if we follow, then approximately 85 to 90% of the children will be managed. I do agree there will be few cases where you will have secondary causes, and in Kerala most of time we must be seeing whatever the cases you have, most of time it will be secondary, either due to cerebral palsy or some other problem. So you will have those kind of issues also. But at the same time, the management, nutritional management are largely based on these 10 steps. And then whatever the secondary causes you have, we will have to manage along with these nutritional care. So just to focus, I will be largely discussing nutritional management. And these nutritional management, the first step is to treat and prevent hypoglycemia, then hypothermia, then if there is any history of diarrhea, then taking care of dehydration, then correcting electrolyte imbalance, treating, preventing infection, then correcting micronutrient deficiencies. And here it's important to realize that we don't start iron initially, even if they have anemia. So we start only when they enter no rehabilitation phase. And then we try to build and first stabilize with F75 diet or starter diet, and then we put them on catch-up diet, or which is also called F100 diet. And then providing sensory stimulation and emotional support by structure play therapy, and finally preparation for discharge and follow-up. So these are the 10 steps which is recommended for these children. So for severe acute malnutrition, the cutoff to identify hypoglycemia is a bit higher. Routinely, we use 45, but for severe acute malnutrition, you use cutoff of 54. So that is the first thing we have to remember. If the child is symptomatic, you will be giving IV. If it is asymptomatic, then we will be giving 50 ml of 10% glucose or F75 diet, which we give. Then we must take their temperature at admission, and if they are hypothermic, you will have to take care of hypothermia by putting them under radiant warmer, or we will have to tell them to use kangaroo mother care. So this is what is step 2. Then the third is, this point is important, and as a practicing pediatrician, all of us, we have to remember that assessment of dehydration is challenging in any child with severe acute malnutrition, because most of time these children, you will find they will have sunken eyes, skin pinch will be very slow. So these signs are not very reliable, and that's the reason we have to remember, and we have to be very careful while rehydrating these children. Although assessment and classification you will have same as you are doing for older other children with normal nutritional status, by using 4 key clinical signs. That is, you will look for general condition, you will look for sunken eyes, you will offer fluid and see whether the child is able to drink or not able to drink. And based on that, you will classify. And if the child has dehydration, I will discuss how to treat. But if suppose the child has diarrhea and there is no dehydration, then you will be giving them ORS to prevent dehydration. So what is important for any, even most experienced pediatrician also, you will have problem in assessment of dehydration in these children. So it's very important that you assume severely malnourished children with diarrhea to be dehydrated, but at the same time you should frequently monitor so that there is no overhydration. So that is the main issue which we have. The second, classically what we read in our textbook, there is a special formulation of ORS for severely malnourished children, which is called Resomal. That is not available in our country. But at the same time, physiologically, what is needed, that these children, they need higher potassium as compared to normal children. And then they are not able to handle the same amount of sodium which normal children they will have. So broadly, if you follow this algorithm, then probably you will be able to manage them better. So what we have to take pre-management weight, then we have to give 5 ml per kg every 30 minutes for 2 hours of ORS. You should measure weight. If there is a weight gain and clinically improvement is there, then you continue, because that's the actual dehydration. If there is a gain but clinically no improvement, then stop rehydrating, give a starter diet and reassess. If the weight is stable and there is no deterioration or pulse rate or respiratory rate increase is not there, then we increase ORS by 5 ml per kg per hour and reassess every hour. But if suppose there is, in spite of giving ORS, there is weight loss, which may happen when they have profuse diarrhea, then we need to increase ORS by 10 ml per kg per hour and reassess every hour. So that's how the carefully measuring weight helps. Now, all children with, whether it is severe dehydration or some dehydration, the general principle is we give 5 ml per kg of ORS every 30 minutes for 2 hours. And this will be followed by 5 to 10 ml per kg of ORS, alternating with a starter diet for next 10 to 12 hours. So what is normally in a normal child, even if it is some dehydration, we give 75 ml per kg over 4 hours. But however, in SAM children, you are doing this on longer duration. So overall rehydration, you will be doing over 10 to 12 hours. And you will be more careful. There will be more intensive monitoring which will be needed. Since we do not have Resomal available, so what we do most of time, we modify the whatever the available ORS is there. But if suppose okay, so what we do, if suppose we do not have and we have facility, what you can do, you can add pot clot dilute 1 liter ORS into 2, add potassium chloride, and so that overall you are increasing the potassium, so overall to 40. So that is what known as modified ORS, which most of the NRC they will be preparing. But if suppose you are not able to do that, then that's not a problem. You rehydrate with ORS, because for any child uh, with rehydration is most important. You can't leave a child dehydrated. So in case you are not able to prepare modified ORS, then in that case you can rehydrate with normal low osmolality ORS, which you are doing for any other child. And we have to monitor. If the child is improving, the child is no longer thirsty, the child is less lethargic, the pulse rate and respiratory rate settling, then you are happy that now this child is improving. And you will stop if the child is now dehydrated. And you will be giving them ORS just to prevent. So that is what is important. As I mentioned, for modified ORS, 1 packet of ORS, 45 ml of pot chlor, and 50 gram of glucose. That is what, and you will make it total 2 liter. And that's how you will prepare modified ORS. So I think 2015 we published. 2015 we published this when we used this modified ORS versus low osmolality ORS, and there was some benefit, and there was some improvement over low osmolality ORS. We documented this. Now, correcting electrolyte imbalance, it's important to give them sodium restricted diet. We have to supplement magnesium, because that magnesium plays essential role in sodium potassium pump. And then if we are using locally prepared, so we will not have adequate amount. So in that case, we will have to supplement with potassium and magnesium from separately. So how much potassium? We use 3 to 4 milliequivalent per kg per day, and you give after diluting with your equal amount of water. Magnesium, the first dose is 0.3 ml per kg, and after that you give break ample and then use 0.2 to 0.3 ml per kg per day. All children with severe acute malnutrition, this is the general recommendation, that they have hidden infection, and to take care of that, we give them broad spectrum antibiotic, and this broad spectrum antibiotic we give them for like newborn, which you give. If it is a clinical sepsis or no other culture proven, then you will give for 7 days. If there is a culture proven, then you will give for 10 to 14 days. So that's the recommendation which we follow. All children with severe acute malnutrition, they have predisposition for vitamin A deficiency. So you give them 1 dose. If they have clinical signs of vitamin A deficiency, then you will be giving 3 doses. One important point to remember is that if there is edema, then we usually wait edema to subside, and then only we give vitamin A supplementation. Also, we supplement with multivitamin syrups. Folic acid, you give 5 milligram on day 1 and then 1.25 daily for 2 weeks. Elemental zinc, 2 milligram per kg per day. So these are the additional supplement which you give, particularly when we are using locally prepared starter diet and catch-up diet, which most of the NRCs or hospitals you will be doing, because commercial preparations are limited and it's usually not available except for Maharashtra, where there are certain NRC, they are using this. So correcting anemia, particularly if these children have anemia, and if it is less than 4 gram per deciliter, then you will give blood transfusion. If it is 4 to 6 with some cardiopulmonary compromise, then you will give blood transfusion. But if it is more than 6, then we avoid in severe acute malnutrition. And if the child has severe acute malnutrition and you have stabilized, then you will add this during catch-up or rehabilitation phase. So that is what is recommendation. And then all children will receive a starter diet. And we give F75 diet, which provides 75 kilocalorie and 0.9 gram of protein per 100 ml. So that is the feed which we give in after admission during a stabilization phase. If the child is hypoglycemic, then we will give 1/4 every half an hour for first 2 hours, and then we will do. Then the next step is rehabilitation phase, and which has 2 phases. One is transitional, and then where you will give equal amount of starter diet which we are giving. Now you will replace it with catch-up diet. And then this will continue for 3 days till the child shows signs of improvement. And then it is important to make transition, because what you are doing, you were giving M75, which was providing 75 kilocalorie in 100 ml. Now, if you are giving same amount of F100, so you are increasing calories and the protein is significantly higher, because the catch-up diet will give 2.9 gram of protein per 100 ml. So that is the change which we do, rehabilitation phase. In this phase, basically the idea is to rebuild the tissues. So you will give them, and before discharge, you will start also home-based diet. And there is a special feed which we use in NRCs. It's most of time it will be limited to NRC, which is called a special feed, where again increase. So we have few studies where we have documented successful outcome in children with severe acute malnutrition using locally prepared therapeutic diet. Then we also documented that these children with diarrhea also, they are managed using locally prepared starter diet and catch-up diet in place of commercial F75 and F100. Then there is very important to realize that all children with severe acute malnutrition, they have some emotional stress also. So it's very important to have psychosensory stimulation for enhancement. Otherwise, they are at risk of permanent mental retardation and emotional impairment. So it's very important, and all NRCs, they are supposed to do this to have play. Okay, I will take questions at the end. A cheerful, cordial, stimulating environment, which is important for these children. And then we will prepare for discharge. It's important to follow these children so that we are not able to know, we can ensure that the child there is no relapse. Now, coming to if this the child was managed in community-based facility-based. So at the time of discharge, they should be sent to community-based management. Or the children who are not having medical complications, they will be coming directly for community-based management. And what is this? This is very important, as you must be knowing. The globally, what they use is MUAC, right? And all globally, the CMM program largely are based on MUAC identification. But at the same time, in our country, WCD department has not endorsed this MUAC. So they are usually identified by weight for length or weight for height also. And there are some also evidence that probably MUAC is not ideal for our country, because only 1/4 of children are diagnosed with MUAC. You will be able to identify, and 3/4 they are usually identified only when this weight for length or weight for height is there. And it is almost similar we had from CNS also. And what you will realize, it is much higher in African countries. Now, the second important point is that globally this RUTF is recommended, as you must be knowing. But in our country, this is again not approved. And our country, why it's not there? Because we have a bit lower mortality as compared to whatever the community-based management, community-based studies are there, as compared to African countries, which is largely because of we have some persistent type of vesting in our country. Second, the acceptance of RUTF is also low. And then overall, the improvement or efficacy is also lower. So there are few of the studies where they have documented, if we have CMAM and manage with commercial standard RUTF, then the recovery rate is approximately 55 to 57. If you manage them with home augmented diet, then it is approximately 47%. So you have just benefit of 7 to 8% with commercial RUTF. If we choose commercial standard RUTF, then definitely the cost will significantly increase. And that's the reason in our country, the recommendation is to manage them with THR and locally available food item. So we had this study with NIN Hyderabad, and so development and use of alternative nutrient dense food item for management of acute malnutrition in India. And subsequently, our WCD also, or on our national protocol also, we had agreement that these children will be managed in community also with similar. But what we have to realize that the health and nutrition education is important component of CMM program. And also there are nutritional management medications, which I will discuss. So first is identification. Then they are given THR and certain medications. Health and education is important component of this CMM program, which we have to remember. And nutritional management is by 5-meal menu plan, where 2 to 3 meals are coming through THR and 2 to 3 meals will be coming from family pot. Overall stress is on nutritional counseling for improving dietary diversity and quality. And this is what we prepared for counseling when they are being counseled in NRC or other one. Then the last component is prevention, and for prevention, you must be aware WHO has updated their SAM management guideline in December 2023, and they have given a newer classification of at-risk infant, at risk of poor growth and development. And this is because if you are not able to provide them intensive support, they are likely to become wasted or severely wasted. And how to identify them? We identify with a certain criteria. When we have multiple measurement, then you will see whether they are maintaining their growth trajectory or not, whether the child is gaining weight or not. Then there are few children who are at risk of poor growth and development because of certain conditions, like they have breastfeeding problem, or there is a maternal risk, physical, nutritional, mental health problem affecting caring practices, or there is history of hospitalization. And then if this is a preterm child, low birth weight, or this is essential discharge, they have higher risk of becoming severely acute malnourished. And then if there is a single measurement, and if they are having moderately underweight, so less than 6 months, this weight for age is a better identification criteria, and which is being used. The WHO in 2023 has also given this MUAC of 11 centimeter for infants between 6 weeks to less than 6 months as one of the criteria to identify infant at risk of poor growth and development. So just to conclude, what are the key messages which we should remember? India has a different vesting pattern as compared to African countries, which I discussed. Then for identification of children with wasting and severe wasting, MUAC has lower sensitivity as compared to other countries, and that's the reason this is not being used routinely. Indian children with SAM has lower mortality as compared to other countries, but same time they have also lower recovery as compared to other countries, and which is probably due to persistent wasting in subset of SAM children which we have. SAM children with medical complication, they are not at such high risk, but at the same time they have 2 to 3 times higher risk of death if they develop some medical complication. And SAM children are managed successfully using locally prepared starter diet and catch-up diet when GI recommendation protocol is adhered. So I think this is what I wanted to discuss. So I see few questions I think I've seen. Let me take first those questions, and then I think we will. If the child is having diarrhea and has persistent hypernatremia, should we make some modification in amount or composition of ORS or amount of composition of feed given? Okay. So see, if there is hypernatremia, then see, you have to follow hypernatremia management protocol. So that is what is important. And when you are using F75 diet, then this has a bit lower. So you will have to take care, and we will have to gradually decline. And so in those cases, you can use normal ORS as compared to low osmolality ORS in place of what I have mentioned, modified ORS. So as I discussed, see, whenever you have some no other comorbidity, we will have to take care of that comorbidity, and we have to manage and follow that protocol. Second is Dr. Sidhu. Community management. Please explain more about THR. Okay, take home ration. So, ma'am, every Anganwadi center, they usually have some take home ration which they usually provide to families for all children less than 6 years of age, and that is what THR, take home ration. And these take home ration, the community based management tells you that 2 to 3 feed you have to use take home ration, and 2 to 3 whatever they are using in home. So the combination of these should be used for management of these children. Okay, so that is what these two questions were there. I will stop here and over to organizers. Thank you.
Sir, please stop.
Thank you, Praveen sir. I think at the outset, I could not welcome Dr. Purushottaman sir. He was actually chairing the session. Over to the chair, sir.
Thank you, sir. That is an excellent presentation, sir, as we expected. I'm Dr. Purushottaman, sir, and I think we met earlier in Thrissur. You were for ETAT in 2018 before
Came. Yeah. Right, sir. Right. I came.
Myself and Dr. Janaki and all better on 5-day session.
Yeah. Right, sir. Right. Yeah.
When we consider the same your integrated management for a Kerala scenario, more and more importance of your studies in the under 6-month category, for where the need for the mother and early infant nutrition status is important, and more that is relevant in case of Atapadi situation, marginalized population and migrant population also.
Right.
The importance of this is that the mothers also are ill-nourished and they are unemployed. And is there any provision to take care of their nutrition also in the coming? That's relevant because when they are ill-nourished, the care of the babies will be affected. That is one thing. The second thing is when they need a facility-based management from Attapadi, they have to come to a tertiary level situation for complicated situations. But during the hospitalization, they need to keep the mother, the father, and in that situation, they are not having any source of money. They don't have much of employment. They can't stay there. So these are all social problems which need to be taken care of. The very same is the problem with the migrant populations also.
I fully agree. Yeah. So, sir, less than 6 months now, we do have protocol, and as per that protocol, usually the mother and infant, they are treated as a diet, and the mother's physical nutritional status is taken care of. The main management is helping these mothers to re-establish lactation and try to improve nutritional status of mothers. Regarding the wage compensation is already there, and for children who are coming to NRC, but then few of the other issues definitely needs more attention, as you have mentioned. Yeah, I agree.
In Attapadis, there are many of these ladies who are having addiction also.
Yeah, I know, sir.
Yeah.
I have visited Attapadi, particularly few of the remotest area when there were some deaths. So I was part of investigation team from center. So we visited few of the terrains and difficult areas, tribal population, then there's customs. So all those kind of issues are there. I fully agree. Yeah.
Regarding the community-based program, community-based screening and early detection part, as you said, we have got the WHO chart defining for the less than -3 standard deviations, weight and all. But the Vidam circumference, is there any provision to integrate that also in that
So, sir, as I mentioned, at this point of time, it is mid-upper circumference is being recommended by Ministry of Health and Family Welfare, but same time it is not approved identification criteria by Ministry of WCD, where largely these programs are being taken care. So whenever the program is under Ministry of Health and Family Welfare, they accept this MUAC. But if it is taken care or being implemented through Anganwadi centers, then there is some issue regarding this. Yeah.
Dr. Sindhu, you can unmute and ask.
Sir, we are having only, I think in Wayanad and Palakkad, we are having this NRC.
Right.
Can we have what is the criteria for this NRC in districts? Because sir told
So,
the rates.
Yeah, I got your question, Dr. Sindhu. The issue is that if you are starting NRC, there should be so much of caseload. So at this point of time, they have approved in certain areas where the prevalence is higher. But same time, it is IFP recommendation. So every health facility, they should have some provision, 1 or 2 bed you have and where you can implement, because see, now we all realize whether it is undernutrition or overnutrition, we have to give more attention to nutritional status. And when we have integrated in our health facility, probably the things will be better. That is what I understand.
Is there any provision for separate funds and for this NRC? Even
There-
in a
there
government
are-
medical college, if you are starting an NRC, we will
So
we
there
get any
are
support for that.
I got your point, ma'am. So there are provision from a state, and most of time the NHM of your state, I think, I do not know who had joined in place of Sri Hari, Dr. Sri Hari. He was initially leading. So they are the best people to guide you what is being followed. Your state NHM, the nodal person.
Okay. And sometimes we find it difficult once the treatment in our hospital, actually in our major colleges, we don't have any facility to provide these foods and all. Actually, the nutrition may compromise because there is no facility to cook the food and all at most of the hospitals. So this, while changing to the home-based foods, we cannot facilitate that.
So, ma'am, what initially when we started, first we documented what is the prevalence in our hospitalized children. We documented, we highlighted this problem, and that's how we established that this is the load which we have and who will need more attention. And we tried to convince them. Yeah.
Okay.
So thank you, sir. It is although we see cases occasionally, it is very we don't have mortality as you said, but it's very tough. The last
Yeah.
case, which I think in Trivandrum, which I had managed, was actually in less than 6 month baby, and that baby had severe atopic dermatitis, skin with a lot of exfoliation and all.
Yeah, yeah.
To some extent, we thought there was some genetic cause, but genetic cause was not there actually, or subsequently. So I would just like to ask, yeah, so you said about this mid-arm circumference measurement and about the weight for height. But sadly, which I think Dr. Sindhu and all will also agree, nobody actually measures a length in our part at least. And if at all, if it is there, teaching hospitals only does that. In routine practice, it is not important. That means in the government setup, so actually, as you said, both that because mid-arm circumference being an easy thing, if it is provided, the WHO that color coded, it'll be actually very easy. Even anybody can do that. So that dual thing should be actually made mandatory, and also that MCP card for under fives. Actually, I think if you say in our place, I have actually personally looked also 100 MCP books we have looked at. Not even one would have had weight or height plotted. I mean, weight, not even a height weight plotted. Because when we say monitoring, because that book is provided, at least it should be provided. But can anything be done for that, sir?
So, ma'am, I think we all have to realize the importance, and then only the things will be better. I fully agree with whatever you were saying. Initially, when we started, and sir mentioned about FMNCA training, which we were conducting, believe me, initially when we were doing this, we were carrying a stadiometer and pentometer with us because most of the places it was not available even in teaching hospital. So I fully agree. I think we need to have this in practice. And as you have mentioned, this is not needed only for identification of undernutrition. Even if we have to identify overnutrition, we need to calculate and plot their BMI. Unless we do that, how we are going to tackle obesity, which is emerging as another problem which we have. So I think we need to plot it. Or ma'am, whenever this is not there, our second option is that we take weight. Whenever this is moderately or severely underweight, you at least for those children you must take length or height and plot it to identify severe acute malnutrition. So two-step identification. That is what we have recently published in IJP.
Thank you.
Yeah.
And also, sir, regarding the appetite test, we actually do not do that appetite test because we always get admitted. The children get admitted. Mostly they are complicated.
So that's fine, absolutely, ma'am. When we are having in a medical college or tertiary care, these children are coming with some medical complication. And if they have medical complication, the algorithm which I have shown, then you don't need to do. Yeah.
That material that we have to make it locally, Earlier, Elizabeth Madam used to have the one sort of our powder with all those things. We have to use our local things only. It's like that.
So whatever is the food item, ma'am, that is being given, you give and try to see whether the child is accepting or not. And that is what is usually practiced. We do not have RUTF, so there is no question of doing that in that way. Oh, yeah.
One more question, sir. do these children actually with SAM develop a chronic metabolic like Barker hypothesis later? Because
So,
we
ma'am,
are
I think this is one of the reason why this RUTF is not being used in our country, because of that risk that we have persistent type of wasting starting from birth, and if we give very high calorie or very high fat amount, then probably there will be risk. Although there are some evidence in some metabolic changes, but it's not proven relationship, because ma'am, for doing that you will have to follow them till adulthood, and we do not have such a study at this point of time.
Thank you, sir.
Sir, it will be interesting to look that aspect, no, sir.
Which aspect?
Sir, you mentioned that these children need to be followed up on a long-term basis, maybe 10
Right.
years, 20 years.
Yeah. So unless we have this, we can't answer this at this point of time. Yeah.
And one more thing, sir, regarding Attapadi, is there any role for environmental enteropathy also for this kind of SAM?
Definitely. See, Prashant, you are very right. Actually, in our country, one of the reason and one of the proposition is that why we have persistent wasting, because of the enteropathy probably in this area. But again, we do not have very good study to document it. So that's the issue. For that, we need to have a study like microbiota and compare and all those kind. So a study is needed, which at this point of time is missing from our country. Also, although there are some study in Bangladesh which is going, and some other country where they have documented enteropathy, and whenever they have enteropathy, then they have persistent type of wasting, and they usually do not improve like normal children.
In Attapadi, there was many cases of hepatitis also at that time. I don't know what is the status at present.
Okay. Right, sir.
And sir, one more question. This is not really related to SAM, because in Kerala we have something called a Nutrimix that is offered as a offered for complementary feed. Do you have such similar things in Delhi also? Because if you look at the nutritional composition of this thing now, is highly sugar laden.
Yeah. So very right. And Prashant, in every country, the THR, that's the biggest problem. And why this problem is because initially the THR aimed to meet calorie requirement, right? That was mode. And second, you wanted to have minimal amount. You have 8 rupees for that whole per day allotment, and in that you have to make. But then now it is being highlighted that whatever we are giving is not ideal, and particularly because of the emerging diabetes and other metabolic condition. And most of the states now they have realized, and they are looking for some modification in that, improving the protein and decreasing the overall sugar content. Yeah. So that attempt is already being is there.
Sir, apart from that, actually, our children's protein content in our diet less. Now people say in adults also the protein content is less. We are more carbs like that. So actually, should we actually change our children's diet? Protein content, other normal children also it is less. That's what now people say. More sugar, carbs like that.
Sorry, there is a lot of disturbance outside, so you must be having disturbance. But ma'am, whatever you are saying is very right. There are documentation, the protein is problem, and the quality of protein is again a problem. That most of time, whatever the protein is also, people are consuming, there is poor quality because the animal source protein is less, and it is more of cereals, which is not very good quality. Yeah.
Thank you very much, sir.
Just
The Dr. Elizabeth, she didn't join.
ഇല്ല എനിക്ക് ഒന്ന് മാഡം അങ്ങനെ ജോയിൻ ചെയ്യുന്നു she did not actually say, she was busy actually. That's okay, sir.
Okay. Dr. Jeetu, any more comments in the chat box?
No comments, I
There
think.
is no other questions, sir.
Okay. Thank you, sir,
Sir.
for excellent presentation. We have learned a lot. especially in the new conception. Thank you, sir.
Thank you so much.
Thank you, sir. Good talk.
Jitu can say that. Thanks.
Thank you, sir. Nutrilearn series is the flagship program of Nutrition Charter, and every month we are blessed to have excellent speakers who serve delicious academic feast to our audience. And whenever we think of malnutrition, personally, what I think is we are learning it for 5 years, 10 years, 15 years, 20 years, hearing the same thing, learning the same thing. And when I think that I can answer 100 questions, on the next day, another child comes up with 101 question. That hypernatremia question was actually asked by me. It was a very very bad child where we were actually baffled, thinking whether we should manage malnutrition or diarrhea or hypernatremia. And Dr. Praveen sir aptly answered that question. Thank you, sir. At the outset, I like to thank Dr. Praveen Kumar sir, the speaker of today's session. Whenever the nutrition chapter has approached him, sir has always been very much approachable, kind to share his immense knowledge and life lessons with us. On behalf of Nutrition Chapter and IAP Kerala, I thank him from the bottom of our heart. Dr. Purushothaman sir, the professor and HOD of pediatrics at MES Perinthalmana, has chaired the session. We all know that he is a prolific teacher. And nutrition, when it comes to nutrition and immunization, is more than academics to him. It is like a heart and soul to Purushothaman sir. Thank you, sir, for your participation and your very valuable comments. Dr. Joe sir has always been a great pillar of support for us. Thank you, sir, for all your guidance and support. Dr. Nandakumar sir, President IAP Kerala, constantly inspire us for newer thoughts and newer programs. Thank you, sir, for your vision and support. Dr. Gopi Mohan sir, Secretary IAP Kerala, is the man who coordinates and runs the show from behind the curtain. Thank you, sir, for always being there for me. Dr. Binikutan sir, Treasurer IAP Kerala, has been doing the technical coordination for the program. Thank you, sir. On a personal note, I also thank my chairperson, Dr. Geeta Madam, who has been behind this session since almost a week. Thank you to all participants, all dignitaries, faculty who have joined from all over the state and country for making Nutrilearn a meaningful academic session. We look forward to your continued participation. Have a pleasant evening. Thank you.
Thank you.
Thank you very much, sir.
Good night.
Purushothaman sir, thank you.
Thank you, Geeta. Thank you, friends, sir.